start with the lecture with the CBCT technology. The agenda is we'll run through a presentation for another 20-25 minutes where you will understand what CBCT is. What are the basic principles? What is the difference between a CBCT and a medical CT? And what is the difference between a 2D image and a 3D image? And soon after that, I will take you to the actual software. I'll take you to the actual treatment planning tools. Alright, so let's start with general clinical imaging. Our body has different parts and we need different type of clinical imagings for different type of anatomy. So let's first understand that. For our brain, we have a very hard covering. We have a very protective layer on our brain which is called skull, and for that we need a medical CT to so that the X-rays penetrate through the brain and give you the view, the internal anatomical view, or the MRI to see the soft tissues. For cardiology, we can use CBCT, we can use a CT, we can use ultrasound, or we can use NMCT. For the entire body, we can use a full CT machine, we can use a PET CT which is a standing CT, or different slice CT, 64 slice or 125 slice CT. And for dentistry or for head and neck region, we have OPG machines, we have intraoral cameras, and we have CBCT which is the latest technology machine. Now there are two types of systems, analog systems and digital systems. In analog system, X-ray machine and human body, they are same. Whereas receptor image processing techniques, display and post-processing techniques are different. In analog system, after we acquire an image, we have the data on the film. Whereas in digital system, when we acquire an image, we get everything on the software. And then we can apply different algorithms to reconstruct that data. We can use different tools to measure different features, different length, angulation, area, volume, bone density. These tools can be applied with the help of a digital system, and you will see it very soon. Then digital radiography imaging type. There are two types of imaging, intraoral and extraoral imaging. Intraoral, I'm sure you all must have used at least once by now, which is the intraoral sensor, or what we call RVG. So in intraoral imaging, we need an RVG and X-ray machine. These are the two things that we need for intraoral imaging. The RVG go inside the patient's mouth. We place the system at the desired anatomy, and then we shoot X-rays and we get the picture or the image on the film or on our PC. If it is an analog system, we get everything on the film. If it is a digital system, we get it on the software. Then comes the extraoral imaging. The name itself suggests extraoral meaning outside the mouth. So here the X-ray source and the detector both are outside the mouth. So in extraoral imaging, there are panoramic imaging, cephalometric imaging, and CBCT. So in pan, you all know X-ray and the detector both are outside the mouth. The system rotates almost 180 degrees around the patient to capture the area between the two the TM joints. Cephalometric, again, it's a single shot image. X-rays comes and puff, you have one image here of the lateral ceph. Either it is right side, left side, or maybe APPA, whatever field that you like. And then comes the CBCT. So the concept of CBCT is the machine rotates 360 degree around the patient and captures the images from different angles. You may say 2 images after every degree. So if it rotates 360 degree around and it takes 1 image at 1 degree, so there are 360 slices that we have. It's kind of a book or the stack of coins. You have slices, you work with the algorithm and you reconstruct, and you have your virtual skull in front of you. We will see it very soon in the software. So here comes the 2D and 3D dental imaging. Let's not waste more time on this slide because we have already discussed a lot about 2D and 3D differences. I'll show you in practical. Alright, can you make out what is this? Shadow, right? But with this image, can we make out where all these blocks are placed? There is a human being we can make out. There are some blocks, but we are not sure what is the placement, what is the positioning. Let's see now. Now can you make out which shadow is of which block? And where is the source? Source means where is the light, or where is the torch, where is the sun? We are not sure. Let's see it now. We have a person and two blocks. And here is our source. So let's go back and see. With this image, we cannot make out what are the placements. Where are these three different things placed? With this either. But with this thing, we can make out. And this is a clear difference between a 2D and a 3D. Alright, so let's see the difference. This is the panoramic image. As we all know, a smiley pan. And what we get with a pan? We cannot get a full mouth series of dental image. No details of maxillary sinus. Inaccurate bone length, because with the 2D system there is always a magnification, there is always a distortion. Inaccurate buccolingual dimensions, because in a 2D everything is on a paper, we cannot measure. Incorrect inferior alveolar nerve proximity, that means the nerve canal. Superimposed anatomical information, hyoid bone, the upper spine, they are superimposed in 100% of the cases. Image magnification and distortion. This is what we get from a panoramic image or a 2D image. Now comes the CBCT. You see it here. We are piling up on the slices. These are the different views that we can get in 15 seconds of the scan. We have our skull in front of us and we can rotate it, we can cut it down, we can slice it, we can snip off unwanted area, and we can do a lot of different things. And with approximately the same dose as a 2D panoramic imaging system gives. And if it is a small scan, maybe 8-second or 10-second scan, the dose is further less than a panoramic image. So with CBCT, what we get is a full mouth series of dental image. We get more accurate measurements because the machine is rotating 360 degree around the patient and capturing the views from all the different angles. So there are no chances of distortion or magnification in the image. Accurate buccolingual dimensions, because we can cut off the slice and we can see it in different coronal, sagittal or axial cross sections. Clear anatomical information, and yes, we discussed no magnification and distortion. Then the 2D image and a 3D system differences. The clinical information is broad in 3D imaging system with a CBCT. Image distortion is negligible. Measurements are accurate. Planning is more accurate, and there are less errors. There are less surprises. The system is very clear. You diagnose it, you do a treatment planning in the software, and go ahead with the treatment. When we acquire an image on an analog system that requires washing or developing of the film with the chemicals, and that takes time. Whereas if we have a digital system, it is in seconds. Similarly, our intraoral systems or our OPGs or CBCT machines, they are connected with the machine, with the system, with the PC, and as soon as the scan is complete, it is there on the screen. And then the benefits to the imaging and dental practice. With the medical CT, Diagnosis of human body is very simple. Detector type is a ring type detector. X-ray tube is high dose tube. The slices that are available with the help of medical CT, they are mainly the axial slices. We get a 3D volume also. Then there is a difference in the contrast, window and leveling, and patient positioning is lying down positioning. Why I am discussing about medical CT is the concept of CBCT is same as medical CT. There is a detector, there is a tube which rotates around the patient, but there are slight differences. Unlike the medical CT, in CBCT, the patient positioning is either standing or sitting. Unlike the medical CT, the slices are not only axial, you will get sagittal and coronal slices also, which are required for dental treatment. Unlike the medical CT, the dose is very less. It is less to the tune of 180% less. And of course, the brightness and contrast or the other tools, the the treatment planning tools which are available with the medical CT are mainly for the medical diagnosis purpose, whereas in the dental there are different tools. So let's see the difference. The beam type in a 2D and a CBCT, or in a CT and a CBCT is, in a CBCT it is a cone beam, and in a medical CT it's a fan beam. Fan means like the blade of a fan. It is a 2D straight beam without any volume. We'll see the difference very soon. The transmitted radiations. In CBCT it is 360-degree round, whereas in CT, if we want to image the entire body, it is 360 degrees plus the spiral movement, like there is a body and CT moves like this. So this is the depiction of a CBCT scanning. As you can see, the beam is conical beam with a volume, and there is a round detector or a square detector which is suitable only for head and neck region. That minimizes the dose. The dose is very less. When we take an image with the CBCT, the maximum that you can get is 270 or 280 microsieverts. It may go up to 3000 microsieverts. And it is illegal to expose a patient who is suffering, and we are exposing that patient to the tune of 3000 microsieverts or maybe 1000 or 2000 microsieverts. The size of the machine. CT machine is large, they are bulky, and CBCT is very small. The footprint is very small. Patient positioning, we know in CT it is lying down. In CBCT it is either standing or sitting up. There are very less artifacts in a CBCT image. If there are metals, if there are there are fillings or there are braces, there are crowns, the artifacts, the chances of artifacts in a CT are way more than a CBCT. Protocols. With the CBCT we can select different protocols, like if you want a single arch, we can have a 4 centimeter scan in height. If we want entire scan for the orthodontic treatment, we can go for 13 centimeter or maybe 17 centimeter in height, whereas in CT we always get a full scan above neck, and sometimes we get our collarbones in the scan. So that's it about the presentation. This is a typical image of a CT machine, how a CBCT machine looks like. This is a sitting machine. You may have hybrid standing machines also, where which looks more like an OPG, where the patient is standing and there is an extended arm for the CEF. So this is a reconstructed image we get in axial, sagittal and coronal cross sections, and we have a volume also. As soon as the scan is complete, within 15 seconds, this view will appear on your screen. and you have now everything in front of you for the diagnosis, for the treatment planning. Now in different treatment planning softwares, we have different tools. We can slice all the way from 1 centimeters to the entire anatomy. We can cut down in axial, sagittal and coronal cross sections, and we can flip the scan. We can cut unwanted anatomy, then different type of measurements. We can create videos out of the software. What we are planning, we can create a video and we can show it to the patient. So let's move tool by tool. There are different tools, like there are volume rendering tools, there are implant planning, there are restoration planning tools, superimposition, 3D Ceph analysis tools. So right now we have our axial, sagittal and coronal scans. And with the scroll of a mouse, as you can see this red line here. I'm scrolling from bottom to top. We are on the maxillary jaw now, and we are now all the way up to the sinus. So here we have our volume. We can rotate the volume also. We can see it from the back. And suppose we don't want anything in this volume, we can cut it down. And these tools are available in different fashion in different softwares. This software is called in vivo software. You have a look at this software nicely. This is the front view where there are different tools, like this is the distance measurement tool. We can measure the distance. This is the angle measurement tool. We can measure the angles. And the area measurement tool. Suppose we want to measure the area of sinus or maybe the airway. We can measure the area, and the readings are available here. So let's move on to the next tab, which is called volume render tab. We have our skull, we have the anatomy in front of us, and we can apply different tools to see through it. We can we can apply different tools to cut the unwanted part and get the desired results for our diagnosis, for our treatment planning. So we don't want this upper spine. Let us cut it off. So we have tools to cut this part. This is the cutting tool, and I'm chopping it off. So this is out, and now we are seeing it from the back side. This is the clipping. I have clipped half of the anatomy, and now we are seeing we are growing the volume, and we can see how the teeth are sitting in the mandibular or the maxillary bone. What is the angulation, how they are placed, what is the width available for the implant. We can measure the width which is available for placing the implants. We can measure the angle of the adjacent tooth. Now let's cut it axially. So this is the axial cut. We can rotate it, and we can see how many roots are there in a last molar or premolar. We can zoom it to see it in more detail. Alright, so this was the axial clipping. Now the coronal clipping. We are building it coronally. There are different views. Right now we are on the teeth view. This is the soft tissue view. We have the airway and the other glands available. This is the soft tissue view. With the skin superimposed. This is soft tissue plus teeth, soft tissue plus bone, and this is the bone view. So we can work on any of the views available to us. Wherever we feel comfortable, we can do that. There are set presets. We can rotate the anatomy accordingly. This is how we can work on this part of the software. Then comes the art section. Art section is the tool where you can draw the nerve. Let me show you how we can do it. I am adjusting the field of interest where we want to draw the nerve. Alright, so we have the nerve already placed. Let's delete it and let's do a new nerve. So we have this slice, we have this half panorama with us. Let us first draw a full panorama. So for drawing a panorama, we need a focal trough. We need to draw a focal trough on the axial view, and then we can go ahead for the nerve tracing. So I am doing a focal trough, and now I have a nice pan in front of me. This is the slice view. I can go to the X-ray view. Slice means the slice of the pan. And here I can place my nerve. So let's do the nerve tracing now. We can do it in the slice view or we can do it in the X-ray view. In slice view we can draw it in a more better way. So let's do it on the slice way. Click on new nerve and keep on clicking, dragging it all the way to the foramen, and done. So we have done it. Our nerve is there. Let's see it in the X-ray view, and we can see the nerve nicely here in the X-ray view because this is the pan with the thickness. Now after doing the nerve, we have the cross-sectional areas. There are two implants already placed. We can move them, we can reorient, we can replace them. We'll do that in the implant planning tab. We have the slices, we have the axial view and the cross-sectional slices. This can be viewed on the software, this can be printed on a film, this can be printed on the paper, and can be viewed in different viewers. Now let's come to the implant planning tab. Okay, let's first disable the clipping. So this is another part of the software where we can place the implant. We have the axial view, we have the coronal view, and we have one area where the bone density is shown. And in this view, the colors around the implant shows the type of bone available around it. White is the highest bone density and black is the bad news, or maybe red or maybe orange. That bone may not be good for holding the implant, and then you have to plan something different for that treatment. Alright, so we have our anatomy and we have already placed the implants. Now let's try to reorient, let's try to move the implants, or let us add one more implant. Let us add 3-1. Able to still, yes. Okay, I am adding a maxillary implant just to show you how we can place the implants. So we have our implant on the cursor. We can drag it and drop it on the anatomy. Now, as soon as we drop the implant, we have the axial view in front of us to align the implant nicely at place. and the color around the implant shows the bone density of the bone available here. We can change the angle also. We can see what is around the implant, and now that we are not happy because this is very near to the other tooth, we can place it in a different way, and then we can rotate it separately and see what is around this implant, what is there in the 360-degree view of the implant. Similarly, we can do it for the other implants. So now I have this one, and I can see how we can rotate this implant. The other one is available in this view. I can move it up, I can take it back, and can you see this warning sign, warning 0.0 mm? That means our implant is too deep inside the nerve. The software gives us the indication that we are very near to the nerve and we have to move the implant up or down. So let's move it up. Alright, so we are okay with this. So this is how we can place the implants. I have placed it in the 3D. We can place it in the panorama also. Here is the panorama, and I can pick and place the implants like this. Like this. We can pick and place the implants. Okay. So the software gives the wrong ID selected for that particular implant. Then there are different view controls. We can see it in a bone view, we can see it in a teeth view. As you can see the difference here, we can see the inverse. Because of the brightness and contrast levels, while the PC is connected with the projector, we are seeing everything white here. But actually it will be the inverse of this. The teeth will be black and the other area will be white. You have distance, angle, volume and area measurement tool. You have cutting tool and video sequence tool. Alright, so now in the restoration there are abutments that we can place. Matching angle to implants too large. Restoration may not match implants. Okay, I'm just giving you the brief idea how we can place these, because there are a lot of implants that we have placed randomly. Now let's plan these two only. Let us move it a little more down and we can align it accordingly. And now this is now ready for our drill guide system. After we plan our treatment here, we can send it in a CD to the milling machines or to the surgical drill guide template planning systems. After this comes the TMJ planning screen, where temporomandibular joints can be seen from 360 degrees with open mouth, with closed mouth. These are the different slices. And we can see it in a 3D or we can see it in the X-ray view. So this is the only thing available in the TMJ. But when you explore the software clinically, you have lot more tools, you have lot more features available here in this part of the software as well. Then comes the Super Pano, where you have a pan. This is a very special kind of software where you have a 3D pan. You have a panorama which has a thickness, and let me enable the 3D of this, and you can actually rotate the pan and see it from the back side. You can actually cut it down and see how the nerve, let me make the nerve visible, how the nerve is moving in the mandibular bone. And we can see it very nicely in the 3D when we have a 3D pan. And this part of the software is, patented software. This is not available with so many softwares, but with the special ones. And then we can see it in different views. We can see it in teeth view, we can see it in bone view. with this kind of 3D pan, the implant planning is very simple because we can clearly see the thickness, we can see the depression inside, the angulation here. This is not the case where the implant may perforate, but there are deep angles inside. You know the clinical term for that. There are deep angles inside, and when we place the implant straight, there may be perforation. Then comes the super ceph. However, this is not the case of a full cephalogram, but this is how you can get a ceph for 2D tracing or for 3D tracing. Then comes the superimposition software. This superimposition is very important when pre-treatment or post-treatments are compared, or maybe after treatment we give some time for healing or some time for changes, and then we do a rescan or evaluation scan. So superimposition can be important there. I can show you how it works. We have our original volume and we can superimpose a new volume on it just to see the changes. Now you can see the white part is the original volume and the blue one is the superimposed volume, and as I have superimposed the same scan over it, we can see there is no distortion, there is nothing changed, but there will be changes in pre-operative or post-operative scans, or maybe follow a post-operative and a follow-up scan. So this is how we can measure the changes. Like in the orthodontic treatments, this tool is very important. After we put the braces, after 2-3 months we can take a follow-up scan and analyze the changes. Gallery is nothing but a gallery where we can save the snapshots. These are the snapshots that are saved already with the crown, the model. The model tool. This is the tool where you can actually wrap a photograph of a patient. This is mainly used for orthogenetic surgeries where maybe mandibular bone or maxillary bone is cut, chin is cutted, and the surgery is planned, and the actual photograph of a patient is wrapped over it just to see how the treatment is going to be. What would be the patient's profile after the treatment. And last but not the least, the reporting tool, where whatever you have done in all the previous tabs, you can create a 5-page, a 10-page, a 15-page or a single page report for your studies, for your thesis, for the patients or for other dentists.